Today we are going to talk about polymyalgia rheumatica and giant cell arteritis, two conditions that exist on the same inflammatory spectrum and that you absolutely must be able to separate clinically, because the consequences of missing GCA can be catastrophic and irreversible. PMR and GCA are not two completely different diseases. They share the same disease spectrum, the same population, and the same underlying immune dysfunction. PMR targets proximal muscles, neck, shoulders, pelvic girdle. GCA targets medium and large arteries, most often the temporal arteries. Both hit people over 50, predominantly Caucasian populations, and carry genetic links. PMR is 2 to 3 times more common, so you will see it far more often. But when GCA is present, your urgency level goes up dramatically. The pathophysiology starts with an unknown trigger that abnormally activates the immune system. Circulating monocytes surge and release IL-1 and IL-6, potent inflammatory cytokines. That inflammatory response makes the vascular endothelial lining vulnerable to attack. In GCA specifically, immunoglobulin deposits accumulate in the temporal arteries. That is the autoimmune mechanism driving vessel wall destruction. Shared HLA haplotypes underlie the genetic susceptibility for both conditions. The whole cascade is genetically primed and then triggered by something we still cannot fully identify. PMR presents with severe proximal muscle pain and stiffness, neck, shoulders, and pelvic girdle. The stiffness is worst in the morning or after any period of rest. Your patient cannot comb their hair. They struggle to put on a coat. These are not vague complaints. They are specific functional failures that point directly to proximal girdle inflammation. Systemic features layer on top: low-grade fever, weight loss, anorexia, malaise, depression. This patient looks sick, feels sick, and cannot move through basic ADLs without significant pain. GCA is where this disease becomes a nursing emergency. Your patient has a persistent headache, new onset, often temporal, jaw claudication, meaning pain that comes on with chewing, and visual disturbances. Blurred vision, sudden vision loss. That visual symptom is your red flag. GCA can cause irreversible blindness and stroke through vascular occlusion of the ophthalmic artery or cerebral vessels. This is not a wait-and-see situation. A patient with new temporal headache, jaw pain, and any visual change needs immediate escalation. Every minute without treatment is a minute closer to permanent vision loss. Use this matrix to lock in the critical clinical distinctions. PMR targets proximal muscles, morning stiffness, and functional limits. GCA targets arteries, headache, jaw claudication, visual changes. PMR carries risk of debilitating pain and systemic malaise. GCA carries risk of irreversible blindness and stroke. PMR gets moderate intervention. GCA gets immediate, strict intervention. When you are caring for a patient diagnosed with PMR and they start reporting a new headache or visual changes, that is not a PMR flare. That is a GCA red flag until proven otherwise. Your two most important lab values here are ESR and CRP. ESR is markedly elevated in both PMR and GCA. CRP and platelet count are also elevated. When you combine elevated ESR and CRP together, the sensitivity for GCA reaches nearly 99%. That is a powerful clinical tool. But remember, diagnosis still begins with physical assessment. You are assessing musculoskeletal function for PMR and head, vision, and jaw symptoms, specifically for GCA. Labs support the clinical picture. They do not replace it. And this is still a diagnosis of exclusion. Other conditions must be ruled out first. The diagnostic pathway has two key steps. First, clinical suspicion and exclusion. You build the case from symptoms and rule out mimics. Second, the steroid trial, a dramatic rapid response to corticosteroids, strongly supports the diagnosis. For PMR, MRI can detect underlying synovitis to confirm. For GCA, you need either high-resolution MRI or temporal artery biopsy for definitive confirmation. That biopsy is the gold standard for GCA. Do not let a positive steroid response alone close the diagnostic workup when GCA is suspected. Get the biopsy. Treatment diverges sharply between the two conditions. PMR gets moderate corticosteroid doses with a gradual taper based on how much baseline inflammation was present. NSAIDs work for mild PMR. GCA gets an immediate high-dose corticosteroid spike. There is no waiting, no gradual titration to start. The goal is to shut down arterial inflammation fast enough to prevent blindness and stroke. Aspirin is added as adjunctive therapy, specifically to reduce the risk of visual loss through its antiplatelet effect. The dose curves on this slide tell the whole story. PMR tapers, GCA holds high. Your two core nursing diagnoses are pain and knowledge deficit regarding the medication regimen. The patient education piece here is non-negotiable and potentially life-saving. Your patient must understand that adherence to corticosteroids is their primary protection against blindness and stroke. And here is the dangerous myth you must bust directly. Patients often feel better and want to stop their steroids. That is the wrong move. Stopping abruptly when symptoms improve does not mean the disease is gone. It means the medication is working. Stopping it can trigger a GCA flare with catastrophic vascular consequences. Long-term corticosteroid therapy creates its own set of nursing problems that require active surveillance. You are watching for infections. These patients are immunosuppressed. Monitor blood glucose. Steroid-induced diabetes is real and common. Watch for GI problems. These patients often need GI protection. Watch for mood changes and depression. Steroids directly affect the CNS. Increased appetite and altered body image are expected and should be addressed proactively. Every clinic visit, every follow-up, every hospitalization is an opportunity to catch these side effects early. Before we finish, let's talk about one of the most important long-term nursing priorities: protecting skeletal integrity. Many patients with PMR and GCA remain on corticosteroids for months or even years, which significantly increases the risk of osteoporosis and fractures. Nurses should reinforce adequate calcium and vitamin D intake, encourage regular weight-bearing exercise, monitor for bone density screening, and promote smoking cessation and alcohol reduction. Remember, while steroids control the inflammation, our job is helping prevent the complications that come with long-term steroid therapy. In summary, polymyalgia rheumatica and giant cell arteritis are closely related inflammatory disorders that primarily affect adults over age 50. PMR is characterized by proximal muscle pain and stiffness, while GCA involves arterial inflammation with the potential for vision loss and stroke, making it a medical emergency. Early corticosteroid therapy is essential, and nursing care focuses on symptom monitoring, medication adherence, surveillance for steroid complications, and protecting long-term bone health.